lecture on how to do a case report. We're going to go all the way down to the basics of the basics so that anyone who has never done it before could probably approach it in a pretty easy way. So the first thing we have to talk about is ethics, and I'm not sure how many times I have to like really emphasize the importance of really following any kind of following all the medical ethics that have been approved worldwide when starting anything, including something simple like a case report. It isn't something new. You have the World Medical Association, the Declaration of Helsinki, Vancouver Group, and the WHO, all of these are groups that have come together and made outlines as to what is considered ethical, what is not considered ethical, and how to really make sure that any research you do is in complying with that, okay? So the first thing that's really important is patient consent. Does your patient consent? Does he or she agree to you putting their story and their, their background and everything and their medical history into this case report, even though they will not be identified? So the first thing is patient consent. You have to get consent, okay? And if you go to the WHO, you can find a template for a form for this patient to sign. Removing identifiers. This is very important. So even if the patient says, yes, you can put my name in it, no, it's still not ethical to put the name in it. So this, in the US, there's something called HIPAA, Health Insurance Portability and Accountability Act, and this protects the citizen's health information. Even if the person has already passed away, like up to 50 years after that, you still cannot use it to use their personal information. The other thing is IRB approval. So International Review or Institutional Review Board. If you have an IRB institution in your institution, they have to approve even your case report. Depending on how extensive it is, it might take a couple days, up to even like a month. It depends. If there's no IRB in your institution, you still have to comply with this kind of ethics, okay? Plagiarism. Okay, plagiarism is very common. Plagiarism is when you copy paste. So you take something from somebody else's journal article, you copy it and you paste it into your own as if you're the one who wrote it. No, it doesn't work that way, and that is against the law. Okay, so there's no copy paste here. You have to learn how to paraphrase, and I'll try to show you a little bit about that later. Each journal might have additional requirements. So they may have certain things that they're not going to accept, and they might have certain other documents that they might accept. Like they might want to see the IRB approval. They might want to see the consent form itself. The last thing I wanted to add here is just authorship, because I think this comes up a lot. And generally speaking, the first author is you, the person who's writing it. Generally speaking, you are the junior staff. And then the senior author is the last author. And this is basically, what's the word? Everyone has convened that this is the way it's done in scientific journals. So senior author is your professor, the doctor who's higher than you, the one who will review it in the end after you have written all of it. In between, you can put anybody else, people who have shared with the patient care, somebody who helped you maybe do the data analysis, different things like that. But once again, first author is you, all right? Now, if you're working with somebody who doesn't agree with this, it's also against medical ethics for you to continue, because this goes against what the ethics are. I mean, if your name is not the first author and you're the one who did the work, then that's not ethical, okay? So, and then like I said, and then here, if you want to learn more about these groups and ethics and the history of all this, you can go to this article, which is by Naven Murphy, Coming to a Consensus on Informed Consent for Case Reports, okay? It's actually a very good article. So here it is. It looks like the PMID is 251-35309, okay? So HIPAA PHI identifiers. What are some things that if you keep in the case report, this patient can be identified? Names, obviously, a particular area that they're from, maybe they're very, very specific place that you can say so-and-so from a certain town or a certain village or certain street, you know. Dates except for the year, so you can't put like the birth date, but you could say the age of the person, right? The exact date of entering the hospital, going out of the hospital, things like that. Taban, obviously, phone numbers, fax numbers, emails. I don't know who would give you their social security number, but if they ever did, just throw it away. I mean, tear it up and throw it away. Medical record number, obviously, health plan, account numbers. There's a whole lot of things here that photographic images, full face. You'll notice that a lot of times if you need to like take a photo of the face, like for example, the lesion is on the face, you would try to block out a portion of the face so the face is not identifiable. You can do that, and so on and so forth. Once again, if you want to go through that a little bit more detail, this is a very good article. Informed consent, like I said, if you go to the WHO, you can look this up and you will find a form that shows you how to fill it out. You take it, you download it, put it into a Word document, and you obviously you put your own institutional letterhead, and you can go through the whole thing. This is a link. We can look at it later if you have, or you can look at it yourself later. Okay, so that is with regards to informed consent. What is a case report? Okay, so now let's go down to basics. So what exactly is a case report? A case report, I'm trying to put the video section a little bit away from the slides so it doesn't cover anything, but okay, here. So a case report is a description of an important scientific observation that is missed or undetectable in clinical trials. This includes either a rare or unusual clinical condition, a previously unreported, unrecognized disease, unusual side effect therapy, response to treatment, or a unique use of imaging or diagnostic tests. So this is from another very good article called Tips for Writing a Case Report for the Novice Author, and I also recommend that you go look through that, 26229-618. So basically, either you're talking about a clinical condition which is unique, the disease itself is unique, the therapy or the response to that therapy was unique in some way, or you used imaging in a certain way or a diagnostic test which was in a certain way. So if you think of the patient's history from the beginning to the end, starting from the signs, the symptoms, their history, the background, management, recovery, all of this together comes together to make a case report. So once again, do you need more examples? This paper is very helpful because you could it actually shows you examples of how to write and how to and certain suggestions. So the case report usually has about 5 or 6 different areas. The title is important. Usually you try to avoid using the word case report or review, but that being said, a lot of people use it and it still gets accepted. It's fine. But you need a title that is descriptive, that is, focused, that tells people, this is what you're doing. Nobody wants to waste time or try to figure out a philosophical case report title. They just want to know, what is this case report about? The abstract. The abstract is different for different journals. So you have to go to the journal itself and kind of see what it is that they want you to put in the abstract. Usually it's not more than 200 words. So it's fairly concise. And you want to think of it as your Google search thing. So if somebody's searching for cases of, plasmablastic dendritic something, you want that to be there in your abstract somewhere. You want, what are you presenting and why is it important? We present a case of blah, 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 and it's important because whatever. Introduction. Usually it starts off with an introduction, and usually there's like a background information about the disease or the treatment or the modality, whatever it is the focus of your case report is. And you're also going to say what you're doing and why it's important. Now, clinical picture goes usually through chronological order. So it starts with when the patient entered the hospital, what were their signs and symptoms, what happened next, kaza, kaza, kaza. And you do this with the mindset of a physician. So if a physician is saying, what was the result of this test? What was the result of this imaging? You have to make sure those answers are all in there, okay? So even though it was negative, you still have to put it in there because, like I said, your audience is a physician who's going to ask those questions. It's helpful to have a checklist to make sure you haven't forgotten anything. Discussion, after that, the discussion is one of the most important parts because, as a reader or as a physician who has not a lot of time, they want to know the summary really quick. Okay, what is this case report? And then after that, they want to go to the discussion to see a little bit more in depth about why this area was so important and why, what they can learn from what you have talked about. So usually you could put some background information on the disease itself or the area of focus, compare it with other cases. If there's like maybe 10 other cases, it's really easy to make a table. And that's really nice for people when they come to look through it. Okay, there's a table, I'll just go look at the table and see if the case that I'm seeing in my clinic is similar to what any one of these other ones. This is really a nice thing to add, is limitations or areas of further study needed. So if this kind of case has not been discussed much, or, you know, for example, you're lucky you work in an Egyptian population which hasn't been described, you know, extensively, maybe in some area or another, you can always say further studies on Egyptian populations of whatever origin or with similar symptoms need to be, you know, further studied, their genetic background or something like that. You can check and see where is the limitations of this case study. And then the conclusion or summary of the above and lessons learned. Now, references are important because they want to be good references that people who want to really sit down and go back maybe to understand more further about this case, they can go ahead and find it. Depending on your case report, you have to look up the author description guidelines to see how many you're allowed. Sometimes case reports, they don't allow more than 15, sometimes not more than 20, it depends, okay? And it's important just for people if they want to have further reading. Now, how do you make your case report special, okay? The idea is anybody can write it, but not everything will be accepted into your journal, okay? So things to make it special include photos. Photos are very good. They're catchy, you know, a nice, good pathology photo of somebody's, you know, disease process, a nice surgery photo, a nice clinical symptom, maybe that's very, you know, pathognomonic or diagnostic. Like I said, putting in a table of cases. If you have more than one of this case report, like you saw in the clinic, maybe 3 or 4, a case series. Case series is a really good way. So basically, instead of, it's exactly the same as a case report, but instead you're going to list each of those patients and then put them into a table and then go into the discussion and stuff. Diagrams are, if they're good, you can put them in. If they're not good, don't bother. But if you have a decent diagram of a unique procedure, maybe, or a very unique or complex clinical timeline that showed, you know, certain things that were changed, you can do that. Like I mentioned, a table of the previous cases that have been described in the literature, and like I said, make it into a case series. Now, how do I know this is a unique? And this helps when you are on the floor a lot. You've got to go out there, be with the physicians. If you're a pathologist, you can go sit with the older pathologists who are signing out. And if you hear the words like, I've never seen this before, then, oh wait, that might be a good case report then, because a lot of it is experience. You don't really know. Or it's something like you are with them, like, okay, we're going to be trying this new treatment protocol, this new, of course, treatment protocol, you should probably be following clinical trials, but that's another whole thing. But I mean, like, for example, maybe a new kind of procedure that accommodates maybe somebody's, something unique to the patient, like their size or their, like a dwarfism, maybe. For example, you have a patient who has dwarfism and you're doing the same procedure you would have done with an adult, but you need to do it on a dwarf, for example, how that might be different. So just being on the floor, being out there, that makes it unique. Second of all, go out there and make sure, check on PubMed. Okay, so you go onto PubMed and you look it up, this case, and see how many other case reports have been described. Read other case reports on the topic. If somebody says there's only been 5 described, well, then this would be the 6th one. So this is the 6th case that has been described and the first one to be described in the Egyptian population. And that makes it unique, okay? Now, how do you choose a journal? This can be very difficult. Obviously, journals, you know, they go through different striata, I guess you could say. Impact factor is basically the number of times that journal has been cited within the past 2 years. So if this journal is a journal that people always go to for sources and information, then it will have a high impact factor. You can look it up and see if it has a high impact factor, okay? Pubmed Indexed. So not all journals can be found on PubMed. They have to go through a rigorous kind of vetting procedure in order to be accepted onto PubMed. if it's on PubMed, it's authentic, okay? Mostly. I mean, they really go through a distinct process to be able to be accepted onto PubMed. So try to stick with a journal that is PubMed indexed. It will make your article much more legitimate. The other thing is that you want to go to a journal that has ethical standards. I mean, something that has, that requests patient consent is a good journal. A journal that doesn't care where you got the information from is probably not the best journal. A lot of the best journals are owned by professional society or entity. So this paper that we're discussing today is done through the official journal of the American Society of Cytopathology. So this professional society has also, a level of ethics and standards and a certain, academic and medical caliber, you might say. So this is also a good idea. You can see what are like the international societies. Similar cases, where have similar other cases been described or been published? So that's a good place to start as well. Interest the reader population. You're describing an Egyptian patient. Is it something unique to Egypt or to tropical areas, for example, parasites, bilharziasis, something that, is very classic or something like that, that might not be relevant in another country like Europe or something, but it would be relevant in like an international society of, Mediterranean nations or something. That might be another area to go. The other thing, it does not have to be organ specific. So for example, once upon a time, I had a case of an ectopic spleen. Okay, so spleen in and of itself is an organ that would be of interest to hematologists, hematopathologists, immunologists. There's a lot of different places that groups of people would be interested in the spleen. Ectopic spleen might be interested for a surgeon, for example, might be interested in that. But we ended up sending it into a obstetrics journal because the other group that would be interested in it is obstetricians, since it can be differentiated from like a wandering spleen or so on that is related to a loss of estrogen, for example, and laxity of ligaments that happens after pregnancy and so on. So this was a group of physicians that would be interested as well. It's not the main group that would be interested, it's a side group, but that would work for them too. So sometimes it's helpful if you have something that in general is not incredibly unique, but it's not very well known, is to choose a group that is kind of there but not. So for example, you have maybe a metastatic tumor that comes from the lung and it went to a unique organ. You can either send it to the group of journals of like lung, thoracic surgeons or so on, or you can send it to the organ that it went metastatic to, for example. I'm just giving you examples. The other thing that you might be interested in is the open access versus circulation. And I don't think this is much of a big of a deal anymore because as time goes on, more and more of these, journals are open access for everyone all over the world. This was more difficult way back, maybe 20 years ago, when it was really difficult to get a lot of these articles. But that might be something you might think of. Now, how do you write? You have your patient, you've decided that you want to write this. These are the steps that you're going to do, okay? First of all, make a checklist for yourself. Do I have everything I need to know about this patient? Age, gender, race, patient history, family history, symptoms, signs, lab results, imaging results, treatment, recovery results, every single thing. And anything else that, like I said, do you remember when I mentioned the negative results? Think like a physician. Was this patient worked up for blah, blah, blah? Does this patient have whatever in their family history? Did this patient showed sign or symptoms of anything else? So make sure you have every single thing you need to do. Once you have all your clinical information, you can move on to the next step, which is, okay, let's sit down and see how to get right. So visit the journal author section. Every journal has instructions on how to write the paper or what they want you to write with. Make that outline on a Word document. Format your references according to what they want. Don't forget to do a spell check. Don't forget to use past tense or at least be consistent in the tense that you're using. Avoid run-on sentences, use paragraphs, and last of all, show someone to edit it, okay? So we can do, before I start into this article, I'm going to go ahead and let's go ahead and start and do like a quick demo, okay? So let's go ahead and start here. So I am here on, regular Chrome, okay? And I've decided that I want to send this article to, we'll just use the place that the journal that I submitted it to, okay? So what I would come here is I would say author instructions, guidelines, American Journal of Cytopathology. Oops, I wrote pathology. And here it is, Guide for Authors, Journal of the American Society of Cytopathology. Okay, so it shows up here, and when you come over here, you're going to find everything. Types of papers that are allowed, contact details, a submission checklist, are all of these included? You know what I'm saying? The different kinds of papers, the copyright, the informed consent, so on and so forth. Go through all of these until you have everything that you need, and then you can go ahead and get started, right? So, like I said, it helps to see another article of the same structure that was accepted in that journal, so you can see how that was written and how that was accepted, okay? So, so let's go ahead and let's do a new share, and I'll show you on, here we are. So you went to author guidelines, okay? And you found out that the outline of a case report is 1, a title page, right? The second thing after that is the abstract. The third thing after that was the clinical picture. And the fourth thing after that was, I don't know, just the discussion. And then you go up and you figure out, okay, how is the clinical, history structured? And majority of places, for example, they have the history, depending on how each journal structures it, you would put the different, different results and so on. And the idea, this is for you so that you don't get confused and forget everything that you need to put in there, right? So signs, symptoms, results, discussions, and then usually and then like, for example, the table is usually at the end of the submission. So like they put it after you've done writing all of that. It's like either a separate document or it's it's in the table. Also, the abstract is occasionally a separate document. So the table and then figures. Okay, now this is just going to help you out so that you can remember everything. Now, when you come to formatting your references, it's important to look it up and see, okay? If you go up here and there's insert citation, so say example, I want to cite a certain journal, so I'm citing a journal reference. I'm showing you this on Microsoft Word because it's very easy. You don't need anything really complex or any extra kind of, what's it called? Software, because you can just go ahead and insert a citation here. Now you come over here and you'll find the different styles, okay? So there is a whole bunch of different styles of citations, and it can drive you nuts if you're trying to, figure out the differences between them, because sometimes it's very, very subtle. It's just like this one wants the date of publishing before, the publisher, or something like that. So APA, Chicago, blah, blah, blah. Most of them are going to be MLA, okay? But when you go to your journal article, the instructions for the guidelines, you'll find out what they want. So if they want MLA, okay, fine. And you're going to insert a citation. Okay, so I've come over here and I want to insert the citation. So add a new source, all right? And this is really helpful because you can go ahead and put the author name, the title. So let's just make up any author. So JJJ and the title JJJJJ and the journal name JSC and the year 1999 or something, pages 22. And then show all biography fields. You could even go down all the way to the month and the date because you're going to need that for most of them. 70, a month of, you know, December 12th, the publisher, second or whatever, publisher, let's say, I don't know, Elsevier. And then, and you go all the way down here, you still have the volume 1, issue 1. I'm just making this up right now. And you go all the way like that. And you can even put in the DOI, which is very helpful now because most journals want you to put the DOI as well. I don't even know what medium is. I'm not really sure. And the year, access, etc. You could add a URL. This is helpful for yourself if you want to go back to it. And then you press OK. So there it is. It goes there, and it will follow you throughout the rest of your writing. Okay. So that is very helpful. The next skill I want you guys to learn is learn how to paraphrase. So I'm just going to go really quickly and get let's see, my tree is shot. Okay, so now I'm just getting something from, let's see. All right, so here it is. Okay, so I'm taking I'm just going to copy and paste out of the paper that I'm going to, I'm just going to copy it, see if it'll paste onto the Word document. Okay, so this is right out of my Word, the document that I wrote, okay? So say that you want to put this into your paper. Can you put it as is, copy paste? No. So how can you rewrite this in a way that still makes sense and still brings the topic across? So TLE1 is an immunostain that shows expression in 95 of synovial sarcoma, although the specificity ranges from 63.7 to 72%. So you could always start a paragraph. For example, you can say the useful, like say, we can say something like immunostains are invaluable, maybe, or shall we say, are important. I don't know. I think you guys get what I'm trying to say. So I'm just trying to say that we can summarize it in a way. You can start it off by saying something general about immunostains are invaluable in the diagnosis of synovial sarcoma, especially that of TLE1. And then you can say something else, like for example, TLE1 is an immunostain that was introduced in, I don't know, whatever, and it works, and it has, and then you can start saying, has a specificity that ranges from 63.7% to 72%. And then you still want to say that it shows expression in 95% of synovial sarcoma, right? So you can say let's see, how should we put this? So then we can say something like, you know, something like TLE1 is, you can say something like, although the range of specificity is wide, the sensitivity is blah, blah, blah. And it will show up to 95% immunoreactivity in up to, oh, wait, it will show up to 90, and that it will show immunoreactivity in up to 95% of cases. Okay, that was torture, right? But you know what? You know what I mean. So you can summarize whatever it is you want to say. Oh, and then right here, you would go ahead and insert your citation. Let's say it was same old JJJ, right? So that way you won't get confused which reference it was you got that from. And go ahead and don't forget to delete the first one because you don't want that in your report. So now you see how you can paraphrase or summarize, incorporate different parts of things into a paragraph or a sentence in a way that you won't be plagiarizing. Okay, plagiarism is against the law. And they have software that like scans through all of these submitted articles to make sure that it hasn't been, put in a different way. All right, so that's it for that part. Now I'm going to start going into the paper itself. Does anybody have any questions at this point before I move on? Alrighty, so let's go ahead and get through the article that we're supposed to be discussing today. So I'm a pathologist, so for me, diagnostic modalities is the area that I would most likely be finding more unique things and so on. So this was a case of, they called it short communication. I mean, it's a case report, but they call it a short communication. Like I said, every journal has a different way, and you have to go to the journal guidelines to be able to figure it out. So so right off from the title, you could see why this was important, because it was a diagnostic challenge, right? So, and made it unique, it was because it was biphasic, but it had an epithelial pleural effusion. So just so you understand the background, synovial sarcoma has both, has usually, it has different areas, okay? So if it's biphasic, when it goes into the pleural effusion, it should also be biphasic pleural effusion. In this case, it was only one component of the synovial sarcoma that went into the pleural effusion, which was confusing because if you know that this patient has a biphasic synovial sarcoma and then you get a sample and it's a different, morphology, or it's just one component, this can be diagnostically challenging. And that in and of itself is not that exciting, but because I guess you could probably figure it out if you know the patient's history well enough. But what made it exciting was maybe the diagnostic modalities that we used to actually diagnose it. Okay, so let's look at the abstract. Let me put this to the side. Look at the abstract. The first thing I'm saying, let me just make this a little bigger. Okay. So the first sentence is a general sentence. What is synovial sarcoma? It's a rare malignancy, right? That commonly involves extremities and joints. It's not a very specific fact that somebody's going to look up and try to find the source. If it's something that's generally accepted and everybody understands, the reference is in there, but for the abstract, that's enough. The next part is, what are we doing? We are describing. What are we describing? A 67-year-old woman who presented with shortness of breath and flu-like symptoms and a chest wall mass. So the presentation was somewhat unique, which is why it's in the abstract, that she came with shortness of breath and flu, and then they found a chest wall mass. The second part, which is pathology, biphasic morphology of synovial sarcoma was noted, as well as immunostains, okay? And then right away we talk about the genetic component of it, which was the fusion transcript, which was detected. And then the next part, where I'm like giving a very summarized thing of the patient's history. Chemotherapy, patient developed a right-sided pleural effusion, and the cytology showed an epithelial front population that TLE1 was positive, and then we confirmed it again with FISH for the fusion transcript. And then I do a summary sentence at the very end, which is, synovial sarcoma can be challenging diagnosis. Where is it challenging? In fluid-filled cavities. When is that even more challenging? When the epithelial component predominates and its original biphasic quality is not seen. Okay? So here, and then I'm saying what we're talking about in this case report, which is telling people why you should read this, you know, if you're interested in this area, is that we're going to discuss the diagnostic challenges of the monophasic and biphasic and talk about updates to ancillary testing. So the type of people who would read this abstract and say, hey, I want to read this, would be somebody who's interested in genetics, maybe of soft tissue tumors. Could be somebody who works with pleural effusions a lot and wants to understand why it's challenging in soft tissue metastases. It can also be somebody who's interested in being up to date on ancillary testing. And it might be somebody who just basically wants to know, what does a biphasic, synovial sarcoma look like in the cytology or anywhere else, or yeah. So now we start to, let's go to the next part. So the way this is set up, like I said, depends on the journal article, the journal guidelines. So the first thing that comes is the clinical presentation. How did the patient present? What was her race? So race may not seem to be a big deal, but actually, like, if you think about this world, and there's a lot of different races that have diseases that are more maybe aggressive in certain races than others, it might be important. So definitely put in, the basic stuff. Here we go, her history. What was her history? Okay, she was a smoker for that many years. She also had asthma, all of this stuff. Is any of this relevant to synovial sarcoma? Probably not, but as a physician reading this, they're going to want to know, maybe somebody one day will suddenly find a connection between one of these history factors, which do not seem to be connected to synovial sarcoma, but maybe one day somebody will find some kind of genetic connection. So a diseased brother who had Hodgkin lymphoma, sister who had cervical carcinoma. Well, this doesn't seem important either, but maybe once again, somebody will notice that they have a cluster of patients who all had, a family that had Hodgkin lymphoma, cervical carcinoma, and synovial sarcoma, and then somebody will come up and say, hey, this is a syndrome of some sort. So negative or past patient history, family history, stuff like that, it's important, even if you don't think it's relevant. All right, now we're talking about imaging. X-ray scan formed at the emergency department showed, the chest wall mass, how it was pleural based, it measured. Once again, you keep in mind that the person reading this might not just be a pathologist, might be a radiologist. Okay, the radiologist is going to want to know, what did this look like, right? And then what did they do? CT-guided biopsy, multiple core biopsies. Okay, these were reviewed at an outside institution, and it was misdiagnosed, or it was, understandably consistent with carcinoid tumor. Most likely what threw it off was the positive synaptophysin, maybe. And also because it wasn't expected as much. Chest wall synovial sarcomas, carcinoids would probably be a little bit more common. I'm not really sure. Either way, I've put in what they found, right? And I'm continuing the story. The story continues. 2 months later, follow-up CT saw a metastases as well as a new lymph node. PET activity. So they recommended that she do a thoracotomy and they reviewed. Okay, next part. This is obviously, like I said, pathology. So I'm going to focus on surgical pathology of the resection specimen. Now, if this was a radiologist writing this, they might expand on maybe the PET avid stuff, talk more about the various, radiology aspects of this kind of case. Either way, so here we are. I'm talking about pathology. Now, the pathology, when you come to describe pathology case report, it's just like reading your own report that you are submitting to somebody, that you are signing out. So I'm going to talk about how big it is, the location, what did it look like. So right out from the report, actually this one, oh, okay, so this was from the outside institution as well. And what it consisted of, okay, so chest wall ribs, it had soft tissue. What did it measure in totality? Intervening somewhat nodular mass. And what did the mass measure? What was it bisected? And once again, as a pathologist, when you read that, you want to know what color was it? What did it look like? How was it inked? So on and so forth. Now, this area would have been really nice if I had a gross picture of it, and that would have made this report also stronger. I did not have one, because like I said, it came from the outside institution. So the next best thing is a very good description. So we talked about how far away it was from the margins. And it's interesting because this isn't something that would be very important, like in a report, right? But it would be more important for like the treating physicians. But we still put that in there. Like I said, the more detail, the better. Where were sections obtained? And let's see. And then we'll go back and review the figures later, just so you can kind of see how they're done. Involvement of the bone was done. And once again, it was signed out, diagnosis atypical carcinoid. So once again, it was misdiagnosed. And then it was sent to another institution review, which is our institution, which was the Ohio State University when I was doing my fellowship there. So histopathology and immunophenotyping. So now, this resection specimen was sent to OSU. What happened next, right? So we reviewed the slides. Now, when you come to describe the slides on, once again, in the pathology case report, you want to do the same thing you would have done as if you were writing the microscopic description on your pathology report. So you're going to talk about generally what it looked like. Were these, clusters? Were they groups? Were they individual cells? And then you go down into more detail. What did each cell look like? Was it spindle? Was it epithelioid, et cetera, and so on? What was the immunohistochemical staining? All right. So, so here I describe it as being a spindle and epithelioid cell neoplasm. And let's see. And then, oh, here's the rest of the part. Okay, additional immunostains. So what did we do in addition to what was already done before? We also repeated the TLE1, which was, oh wait, it wasn't done previously. Okay, so TLE1 was positive, and I chose to put that in the figure, right, because that is important. The cytokeratin, and again, synaptophysin was partially positive. Chromogranin was negative, okay? And then we did a whole bunch of other stuff, which were all negative. Obviously, I'm not going to put all of those pictures because they're all negative. Molecular testing is the next part. And so that was done with total RNA. And here you need to have, sometimes you need to get the help of somebody who actually did it, like did the molecular testing. Okay, what exactly did you use? How is it extracted? And once again, go back to the author description, the author guidelines. Sometimes they want to know what company the primers were from, what company was the, everything. They want to know like the details of exactly what kind of things you use to actually do the genetic testing. So we did an RNA, reverse transcriptase, genes, and so on and so forth. And the integrity, how is it assessed? See, I as a pathologist may not completely understand all of this, but the molecular pathologist who helped in this part, she was helpful enough to explain it, and so that we could put it into this part of the report. And then she actually reviewed this paragraph to make sure that it was, it made sense. So it's always helpful to have more than one person. You don't have to do this all by yourself. All right, continuing the clinical picture. This was a clinical part. The patient had chemotherapy. I've put in the kind of chemotherapy they've used, although once again, as a pathologist, they might not be that relevant. But maybe a surgeon, maybe a chemotherapist, maybe an oncologist is reading this, right? And so, and then the PET scan showing the progression of the disease. Again, then the next part, cytopathology of pleural effusion. Now, this is a cytology journal, so this area is really important because everybody who's reading this, for sure, will have, or at least, you know, the majority of people who are part of the society and want to read this journal will read this part. So I'm describing how much, a total of 900 mLs. What did it look like? Cloudy yellow fluid. Where was it from? A thoracocentesis. How did we work? How did we process it? 2 cytospens. What did we stain with? Pap stain, diff quick, and subblock. Once again, sometimes you have to actually put where is the company that you bought this stuff from. Cytology and immunophenotyping. All right. So this was another, and once again, it's very variable in case reports. I followed the structure of previous case reports that were put in that journal. And they usually had a separate area, for example, for immunophenotyping. You don't have to do that. This could be part of the, you know, the paragraph before under cytopathology. But here, this is how it's structured, and this is how the readers of that journal expect it to be. So, what did we see? Clusters and balls of cohesive epithelioid cells. Okay, so that's what the cells looks like. And what did the cytoplasm and, you know, the Saito Morphology look like? Fine to dense cytoplasm, pleomorphism, anisonucleosis. Discohesive cells were also seen, varying in size, smaller cells, round nuclei. What did it look like under Pap stain? Was there mitosis? Yes. Was there cleaved nuclei? Was there any rosette formation? Yes. A background. What was the background? Okay, the background had lymphocytes, rare neutrophils. Cell block. Okay, so we usually do a cell block. Cell block, for those of you who don't know, it's like the cytospin, which is the fluid, gets, you know, compacted into a smaller group together and is processed as a tissue, like a histological specimen. And that's the one that's the immunostaining is done on. Some places do immunostaining on the cytology itself, but the cell block obviously is better because, you know, you can actually, it's just more easier to read and so on. So what did the cell block look like? Okay, so the cell block showed, now I'm describing it as if it was a histopathology specimen, right? Rounded cleaved epithelioid cells, the fine nucleoli, a conspicuous nucleoli, excuse me, darker nucleoli, homocyte rosettes. Yeah, there was rosetting, ribbon-like. In light of the patient's history, and then I say what we did next. What did we decide to do based on after seeing this morphology? We ordered immunohistochemistry. So we ordered TLE1 again, CK7, P16, okay, and P53. It was negative for TTF1, PAX860, CK20, and tau. And this is important too. For confirmation, before we, you know, finalized it, we sent it out for FISH to make sure that yes, this is the patient's synovial sarcoma. Okay. So now we go to the discussion, right? And the discussion kind of brings us back to focus why this case was important and why we reported it. Synovial sarcomas, the rare malignant tumors accounting for 5 to 14% of soft tissue sarcomas. Here is my reference, okay? This is not something that you just make up, right? But you can do your own. So for example, if I did this, say, in a larger place that had many synovial sarcomas, I could potentially go back maybe over the past 10 years and see how many cases, how many soft tissue tumors there were and how many of them were synovial sarcoma, and then I could add that here and say something like in our institution, synovial sarcomas account for approximately, you know, 20 to whatever percent, say if it's, and what if you find out that it's very different from here, then that could be another part of your discussion where you could say it would be important to explore why there is such a high level of synovial sarcomas in our population. I'm just giving you an example. So here I'm just saying that they're rare malignant tumors accounting for 5 to 15% of soft tissue sarcomas. And then I put in some background history. You don't need to do this, but I like to do it. When was it originally described? Who described it? I even got the reference all the way from 1865. This stuff is available. 1914, 1934. And then I described why they came up with the name synovial sarcoma, because they thought that it was related to the embryologic synovium. And then here I put in a comment, which is, even though we don't know the exact origin, it likely arises from pluripotent mesenchymal cells that acquire the ability to differentiate through the mutation of this. And then I put these references. Okay, so this is a nice beginning paragraph. I talked about history, I talked about the name, I talked about, you know, what the origin is. Okay, it's just an introductory paragraph. From a clinical standpoint, synovial sarcomas occur in a very I'm still doing a general discussion right now. I'm talking about the general background. Who does it usually affect? Are they women? Are they men? Or what ages do they happen? Where is it most commonly occurring? Okay, so what about metastatic disease? Yes, it occurs in blah, blah, blah. Why is that important for this case? Because this patient had a chest wall mass and it was involving the pleural. Mets occur mainly to the lungs. This might be important for somebody who's interested in chest wall and thorax, right? Less common areas have been described. So somebody coming to read this paper might have a case of synovial sarcoma in the kidney and they want to see, oh, okay. And then that person might actually go and check my reference, like say, hey, I want to read more about that, so let me go there. Local recurrence, blah, blah, blah. This is all a general background about synovial sarcoma. Prognostic factors, right? Monophasic have a worse prognosis than biphasic. All right, now I'm going on to more specific to my case, which is chest wall. Okay, so it's a chest wall. Is that common? Does that happen a lot? No, it's very rare, with fewer than 10 cases reported in the literature. And I put a couple references, 1 and 10. Now at this point, if I wanted this to be stronger, I could have made a table of all of the previously described chest wall cases. What happens is I think I saw one of these other reference had already done that, and so I thought it might be redundant, especially since I'm mainly focusing on like the ancillary testing here. But like I said, if this is your case and this is your number 10th case, go for it. Make a nice table with all of the other literature, each one that was described, okay? Common presenting symptoms are chest pain, dyspnea, cough, blah, blah, blah. Imaging, now I'm talking about specifically chest wall synovial sarcoma. How is it different from anything else? What is the radiology that's specific for it? And this might be important for a pathologist who's trying to read, you know, the patient's radiology, and they notice that, hey, this patient's radiology is very similar to synovial sarcoma. Maybe this patient has synovial sarcoma. So why is it a challenge? Because it has a wide differential, which includes, yes, lung and pleural-based tumors. And then I break it down into the two different types. You have the synovial sarcoma with a prominent spindle cell component, and those with the epithelial component, and those that are biphasic. So the ones that have a prominent spindle cell component, you would have to distinguish it from other spindle cell tumors, right? The ones with a large epithelial component, you'd have to distinguish it from more for the epithelioid tumors, right? Saito Morphology. This sentence is important because I say it rarely involves the blood cavity. Its Saito Morphology has not been thoroughly described, okay? So it's something that I say right off the bat, what we describe is something that has not been commonly described. So how is it different on cytology? The description of cytology, the architecture, the background. Again, you're talking to a pathologist, so we want to put all of this in there. Now, this sentence is also important. Biphasic synovial tumors on metastases lose their epithelioid morphology, retaining their spindle cell component. So this is what makes my case report different, because we report a different occurrence. Instead of when the biphasic morphology of the chest wall lesion was altered in the pleural effusion, it showed a loss of the spindle cell component, and instead of the loss of the epithelial component. Okay, so all right, and then I mentioned other rare types. Okay, now I'm talking about the next part, which is important, which is ancillary testing. So ancillary testing has made so many changes in the past, how many years? This is the sentence that I highlighted to show you guys how to paraphrase. Anyways, my favorite word, invaluable. Okay, for the accurate diagnosis of synovial sarcoma. Immunohistochemistry is a convenient method that can be used easily on paraffin blocks. TLE1 shows the expression, blah, blah, blah. Decreased expression, and so I'm talking a little bit more about TLE, is noted in subtypes such as pleural pulmonary synovial sarcoma, calponent undifferentiated, and there is my reference again. Other immunostains helpful for ruling out the other spindle cell tumors that we mentioned. And then the epithelial component, other immunostains, would depend on the site of the tumor. So since this was a chest wall, pleural effusion, the first thing you think of is lung, obviously. So maybe TTF1 and napsin A and so on. So we ruled out adenocarcinoma or mesothelioma. And then we talk about the strange thing of the synaptophysin being positive. And this area is what I did a mini search, and I found that a subset of synovial sarcoma tumors with granular submorphology were synaptophysin positive, and we did not see that. And so I talk about what is important to be described further. Further studies are necessary to explore possible other rare types of synovial sarcoma that might be synaptophysin positive. And that's something for the scientific-minded to consider. Somebody else might go ahead, like if you found a group of 10 cases of synovial sarcoma of the chest wall and do a whole bunch of synaptophysin on it and see is it consistently positive, then you would report that synovial sarcomas that are chest wall origin are also positive for synaptophysin, but you would have to really do that thoroughly and make sure that all of them were done correctly. All right, now we're talking about molecular testing. Okay, so gene fusion analysis or break apart FISH has become standard in the diagnosis of synovial sarcoma. Obviously, we're talking about in the US, but 95% of synovial sarcomas are characterized by this gene fusion. Okay, and then I talk a little bit more about the difference between the biphasics and the monophasics. And then I'm talking about newer forms of molecular testing. So now they have something like a complexity index in sarcomas. And what they do is a huge panel to see the genomic character of these characters, whether it's primary synovial sarcoma or metastatic. Also notice they also check for the prognostic risk, like metastatic risk. Biomarkers that may be used, these ones are not that common, but they're being used, they could potentially be used for evaluate recurrence or metastatic disease and help determine prognosis. The examples include blah, 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 blah. Conclusion. All right, so what's the conclusion? Synovial sarcoma is a rare occurrence, and involvement of the cavities can pose a diagnostic challenge, and ancillary testing with immunohistochemistry and molecular are essential tools. Okay, so I'm going to go back now and go through the figures because I want to show you guys how we kind of formatted these figures and made them look okay. Now, generally speaking, when you come to do the figures, you have they want you to do a what's it called? A composite figure. Okay, composite figure like on PowerPoint. So you take a whole bunch of different figures, you put them together, and then you save as picture, and it becomes one picture. So this is one picture, this is another picture, this is another picture. These are all these different pictures. You put an A, B, C, D, E, F on them. Once again, you have to go to author guidelines and see if they have a maximum. Like if they want your composite picture to have a maximum of 4 pictures, for example, 1, 2, 3, 4. I'm sorry, hold on just a minute. Sorry about that. So like I said, you've made it into a composite picture. You put those ones on. You want to choose the areas, the pictures that are most expressive of whatever you're describing, obviously. And then you look at the way it's described here in the figures. So A, resection specimens, so they know where it came from, right? What exactly does it show? It shows clusters and groups of epithelioid cells alternating with spindle cells. And then I describe what kind of staining I used, okay? B, resection specimen, again, what it shows. Immunohistochemistry, showing positive, blah, blah, blah. Sometimes here you have to put the company, like I said, like DACO or whatever. Immunohistochemistry showing the positive TLE. So right now it's sort of like this is the proof of what I was saying. This is what we have. Immunohistochemistry showing positive chromogranin. So you can see some areas of positivity. It's not strongly positive, obviously, but it is, let's see. What else? So, I'm sorry, I just got confused. I just got distracted. So, E and F. E is the positive synaptophysin. F is the, it should be negative chromogranin. So this is actually a typo. See, this is very interesting because not only is this edited by me, it's also edited by the journal, which is also edited by a whole lot of other people. So this is actually a typo. It should be negative. Okay, next, over here is the next group of figures. Once again, I have all these figures, I put them together, I make it into a table on PowerPoint, and then I say save as picture, all together becomes one picture, okay? So here, this is the pleural effusion, all right? What am I seeing again? I'm describing it. Clusters and groups of cohesive epithelioid cells with cytoplasm, blah, blah, blah. Pleural effusion, what am I using? Pap stain, Papanicolaou stain, right? And then the cell block. Cell block, like I said, looks like histology. So here's what it looks like on lower power, higher power. Pathology, you always like to put like a mixture of higher power and lower power. Those together will all be fine. Immunohistochemistry, again, it was positive for cytokeratins. Positive TLE staining, okay? Over here is the figure. Once again, I had the molecular pathologist do it, but if you understand fish enough, you could probably just write it yourself. But I had to put in exactly where the probes were from, what kind of probes, and as you can see, the rearrangement in the majority of tumor cells, okay? Let me see if we have any other pictures here. I think that's it. Let me go through my references just really quick so that you can see what I mean. In the background, if you go through like what I was talking about, these are the really old references from 1865 and from 1914 and stuff like that. And then you'll also find like more recent ones. This was 2015, MR imaging. So pretty much everything that I've mentioned before, you will find the reference for it. And these are 20 references, and that's it. All right, so that's all for this case report, and you guys could go ahead, and if you have any questions, go ahead and ask, or otherwise, yeah, I'll give you a moment to see if you have any questions. All right, everyone. So in that case, once again, I tell everybody, practice reading lots of case reports. That is more than enough. That will help you a great deal. Keep your eyes and ears open for anything interesting on floors, if you're signing out, if you're, you know, in the radiology room, anything and everything throughout your, if you can get a case report by the time you graduate from medical school, that would be awesome, okay? And work with other people to make it happen. And that's all. Thank you so much, everybody, for joining us. I appreciate it. Thank you. You're welcome.